All right, well, hello everyone, and welcome to today's Webinar Wednesday. Our topic today is social determinants of health in healthcare, a background and current state for community-based organizations, presented by Dr. Shannan Swafford. So as it has been in past reviews, Webinar Wednesdays, the chat is open for you to interact with your fellow attendees. If you do have a question for our presenter, please put that in the Q&A section, and they will answer that at the end of the presentation. So a little bit about our presenter today. Dr. Shannan Swafford is committed health information professional and a lifelong learner, and a bit of a healthcare rolling stone. She has experienced many settings, including hospitals, physician offices, a QIO, IT, a payer organization, course development, and as an occasional adjunct faculty member. Combined formal education across healthcare and business, plus various roles held in these organizations, inspired Shannan to take the leap from corporate work to entrepreneurship for the freedom of creating solutions to hard problems from healthcare information lenses. Shannan has a volunteer spirit and has experiences including jail ministries, facilitating classes for those hurting from divorce, board members for local community center, and many volunteer positions for health information profession. Live fully, learn continuously, and love much as possible are some of the lifestyle choices that keep her moving forward. So with that, I would like to turn it over to Dr. Swafford.
Thank you so much, Ashley. Thank you all for having me today to talk about some important work that we're doing in healthcare combined with community services that have been provided for as long as I can remember. So I appreciate that you all have joined us. I am, as you can hear, I'm not from the Midwest. I am a Southeast Tennessee person, and I do love volunteering, and I love my rural community. And I've worked in a lot of urban and rural healthcare settings, and I've volunteered in both rural and urban areas. And but I do talk a little funny. I'll start with a little bit of humor when I start a presentation. Sometimes if it's not in the South, I will say, if I say a word you don't understand, put the long I sound in there. And if that word makes sense, that's probably it. And if that doesn't make sense, then stop me and ask a question. Ashley is going to monitor the chat for us. So if you have questions, feel free to put them in the chat anytime throughout. And then we'll get to those at the end, unless there's something prevalent. Ashley, feel free to stop me anytime that you need to.
Yeah. Before you jump in, it looks like we have the speaker slides showing on our side. So
I do this. So this was why we practiced, and then I still didn't get it right.
All right.
Let's see. All right. How about now?
Perfect.
Presentation slides. Wonderful. Okay. Thank you. So let's talk a little bit about social determinants of health in healthcare, SDOH, and what does it mean for community health workers and community-based organizations. And, it's interesting because it's almost like healthcare is late to the game from a game that you all have been leading and championing for years. And the point here is you all have incredible resources and incredible skills that are absent in large part in the healthcare industry. And it's not that we haven't been in healthcare caring for a person. We've been caring for people, but we've been caring for people from a medical standpoint. And then in recent years, maybe in the last 20 years or so, combining that with behavioral health. But now we're kind of moving into the reality of the trifecta of behavioral, medical, and social care together. And so we're going to talk today about, why does this matter? What does this mean for community health workers that the healthcare industry is kind of coming into your space? And I'll share some statistics with you. I'll simplify those. They're kind of large numbers sometimes, and I'll explain through some of the healthcare statistics, kind of what that means, in case they're new statistics for you all being on the community health worker side. So, see how slow my slide deck is. There we go. Okay. So I don't read from my slides a lot. I usually will talk through them, but I am going to read the World Health Organization's definition of social determinants of health, which I feel confident that you are probably all more versed in than I am even. So social determinants of health, or SDH, are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and then the wider set of forces and systems shaping the conditions of daily life. And some of those examples are income and social protections, education, unemployment and job security, food, housing, transportation insecurities, social inclusion, and non-discrimination. And there are more. And quite honestly, this list has grown a lot. Even in the last 7 or 8 years, this list has gotten more inclusive of other socioeconomic factors that are impacting health and outcomes for our people. So why is healthcare asking community health workers for help? Well, as I kind of alluded to in the beginning, you all have been caring for the needs of people in your community for as long as you've been doing this kind of work. So asking you all for help is kind of a multifaceted uh, really phenomenon, I would think, really, is because your boots on the ground, the community already knows you. You've built trust in your communities. You've been serving in your communities, and you understand the needs. So you understand those community needs better than the healthcare industry does. So your knowledge and your kind of boots on the ground services that you've been providing, it's very important to the healthcare sector. In addition to the knowledge, as I said, you've built trust. It takes a special person to be a community health worker and want to serve in their communities, and to do so in a manner that community feels heard and seen and served, and you all do that well. The interactions that I've had with community health workers and social workers, just incredible in how they deliver support without any kind of stigma. And one of the reasons that we have this challenge in healthcare is because of some of the stigma that is around asking these social determinant of health type questions when you're in a healthcare setting. Another reason is that 80% of health outcomes are related to social determinants of health, not necessarily the medical care. So if I'm in a hospital setting and I'm being treated, my nurses and environmental staff and all of the support staff, they're bringing me 3 meals a day unless I'm on a restricted diet. They're monitoring my input and output. They're making sure I'm hydrated. They're checking my temperatures. They're distributing the medication. Those things, when I'm in medical care, I'm doing a great job. Most of the time, we're doing a great job at serving you while you're there and treating your medical conditions. But when we discharge you, or transfer you to a different place, not understanding your situation at home, we can't be sure that you are getting 3 meals a day. We can't be sure that you can afford your medicine. We can't be sure that you're taking it as prescribed, or even understand how to take it. So the outcomes are driving some of this, the recognition that we need to do better at outcomes, and we're not necessarily doing a poor job in medical care itself, but in that transition, we need some support. Whole person care also is very inclusive of medical, behavioral, and social, as I said earlier. The healthcare systems also have major resource limitations, probably throughout COVID and beyond. And even today, you've probably heard a lot of conversation or read some articles about the healthcare worker burnout, and that a lot of clinicians and even administrative and support staff in healthcare settings have stepped away or have pulled back because they're just overworked. So there's a lot of overworking. There's also resource limitations of they don't have the community boots on the ground in the same way that community health workers do. So the having to try to figure out, where do I send a person who has a need for covering a food insecurity, that's something that community health workers would understand and know. And it wouldn't be a resource intensive process for that healthcare worker if they were partnering with community health workers. Another reason for healthcare to be involved is the quality incentives that are associated with asking and then responding to some social determinant of health needs. Those quality incentives are not yet, they're not really massively used. They're mostly indirect, which we'll talk a little bit about reimbursement in a little bit. They're mostly kind of indirect quality incentives at this point, but there are also now in the revenue cycle of healthcare, that's healthcare payments, like, filing the claims and putting on diagnosis and procedure codes, and then getting a response back from a health insurance company or Medicare or Medicaid to say, we're going to pay you X for this type of thing. So there's a lot of healthcare payments now. So because of the regulatory environment, we are now having some serious focus put on paying healthcare for some of these services around social determinants of health. And so there's a lot of need, and there are resource limitations, and there are financial considerations. So there's a lot of reasons that we're asking. I'm going to ask you all to put in the chat. Now, this, hopefully I will be able to update this information with different data sometime maybe in the middle of 2025. But according to market research and to existing empirical information, the healthcare industry has how much social determinant of health data on patients, or if you're a health plan, on your members. So I'm going to give you a few responses. Do you think there are less than 1.75% of patients that we have healthcare social determinant of health data on? Less than 5%, but more than 1.75%, greater than 10%, or about 50%. So if you'll put some responses in the chat, do you think as a healthcare system, how many, what's the percentage do you think that we have? And I'm going to give it just a couple of seconds before I reveal that answer. I see the chats starting to come in.
Would you like me to read it out? It looks like we're getting a lot of A and B.
Very good. Very good. Okay. Well, thank you for that. And I'll go ahead and move. I see some still coming in, but I'm going to go ahead and move on. The answer is a little less than 5%. That is across the board. That's been true. There are some populations of healthcare, really health insurance company members that you have more data on. And so those are going to be like what health insurance companies would call LTSS patients. So patients that have specific special needs, like handicapped folks or aged folks that have some pretty significant disability in maybe they had a hip replacement and they can't move anymore, and they moved into this more acute need. So those populations are going to be a small population within each health plan. They've contracted with Medicare and or Medicaid to provide additional services for. They're going to have maybe upward of 75% of SDOH information on those particular patients, but they're also paid a significant premium to help manage the care for those patients. So in small pockets, we may have more data, but as a whole and generally speaking, we have about 5% of information. Data collection is another way that healthcare could use support of community health workers. So we sometimes in a small town, and I don't know, maybe it's true in a larger town also, you may go to some social thing with your provider or your nurses or your medical assistants at your provider's office. Maybe you go to church with them, or maybe you go to the gym where they go, or maybe your kids go to the same school. And asking these questions that have similar stigma as the behavioral health questions that we have historically asked in healthcare. Asking these questions are sometimes uncomfortable for the patient. And so having those relationships already built where there's trust and understanding that you actually exist as community health workers and community-based organizations to serve these types of needs. Community-based organizations and community health workers potentially have the ability to have more honest responses. So even just having you all ask the questions is something that we could potentially benefit from to help achieve whole person care. So what is care in context? And I won't spend a lot of time here, but this is really social, behavioral, and medical care all together, but it's bringing it together where it's direct patient impact. And by having that direct patient impact, you're impacting your community as a whole because you're helping either improve and or maintain the healthier life of the people in your community. And when you think about a community impact, it's not just what your organization is doing or your similar organizations are doing as community support, but imagine the data that you can collect and share back with your municipality to say, hey, we have, you know, 75% of the people that we serve have utility needs, or 68% of the people we serve have a food insecurity that they have food for the first 3 weeks of the month, but for the last week of the month they really have a hard time maintaining and keeping food for their family. Imagine if you could take that actual data and share it to municipalities so that they could then start to build some infrastructure for that, so that you move it from being reactive to those needs to being a proactive community. So there's a huge opportunity for community impact there. And then organizational impact there, this is twofold. So there's healthcare organizational impact, and then there's community-based organization impact. So in the healthcare side, as I mentioned a little bit, quality incentives, but also healthcare revenue cycle or healthcare payments. The healthcare organizations that may be pursuing partnerships with you, they definitely have a financial opportunity here, because if they're actually moving into treating and caring for these folks in two ways: social determinant of health, but also health related social needs that are a little more detailed and involved, then they're able to say, we're doing this, we're doing more in the transition of care. And so by doing more in the transition of care, we also understand that you're going to pay us a higher rate of pay for this particular thing. But also, in addition to that, it's community-based organization impact, because if you understand some of this revenue cycle and some of these incentive payments and how things are paid in healthcare, this will give you leverage to contract with healthcare organizations where maybe there's not a large payment for you if you're doing general social determinant of health support. That's kind of what you do right now, all day, every day in most cases. But for those health related social needs, those are billable, reimbursable events that you could understand how that works in healthcare and then use that to build sustainability for your organization. So start revenue generation, still be nonprofit, still be well within the confines of serving your community, just receiving enough support to hire the staff or to buy the technical resources or to increase the amount of food you can purchase or utility support you can provide, whatever your particular organization serves and what your community needs are. This is a way to help kind of build some sustainability for your organization as well. So here's where we're going to get into a little bit of the statistics, because this is important to understand what is this impact on healthcare. We're going to talk about just two. We're going to talk about food and we're going to talk about housing and what happens to patients if you provide food where there's a food insecurity, and what happens to patients if you provide housing when there's a housing insecurity. So first, let's talk a little bit about how much the healthcare industry really contributes to the gross domestic product in America. So I wanted you to notice I highlighted in 2000, healthcare expenditures were $1.366 billion annually. That has almost tripled in 2022 to $4.464 billion. And that is significant. It's huge. The implications of what this cost, and it's not just what it costs that person, and it's not just what it costs that healthcare organization. It's also what it costs Medicare, what it costs Medicaid, what it costs employers, what it costs the community. I mean, this is a significant impact. So if we're able to decrease some of this expenditure, it's not only decreasing this expenditure in healthcare, but it's also by default. Maybe this is the default outcome of having better quality outcomes for the humans that we're serving, right? So for food support, if you provide food, then there was a 49% reduction in admissions to healthcare into the hospital. There was a 44% reduction in emergency department visits if you just provided food that was not tailored for a medical condition. If you provided medically tailored meals that were specific to conditions, there was a 70% reduction in ED visits. 70%. So, in other words, if I'm a person that continuously, if I have diabetes, type 2 diabetes, and I do not have access to healthy food, then every couple of weeks, then I'm probably going to find myself in a place of diabetic ketoacidosis where my blood sugar levels are very uncontrolled, and I may have to go back to the emergency room to get that leveled off. Well, by providing meals that are specific to a diabetic situation, it's medically tailored. I can reduce that by 70%. So if a person had 10 visits per year, you're reducing that to 3 visits per year to the ED, which is significant. You're making a huge impact, yes, on the cost of care, but also to the outcomes. And for this person, they have a better quality of life. There was also a 77% reduction in acute care utilization, which can be emergency room, it can be urgent clinic, it can be PCP visits, or it can be even some admissions from acute situations in a hospital or into observation status. For housing support, there was a reported 53% reduction in admissions when housing is provided. 57% reduction in ED visits, 34% reduction in costs for housing, primary care, and behavioral health when you provide it. So if you provide housing, provide primary care, and behavioral health cost reduced by 34% just by providing someone safe place to live. This is the most significant for the overall impact to the large number of people that have chronic conditions. When you provide housing for a chronically homeless person, you are reducing their cost of care by 43%. And imagine the quality of life you're changing for that patient. Now, I know that you all understand this because you're community health workers and you represent community-based organizations. But in healthcare, we know this, but it's a challenge for us to bring those things together. So kind of another reason is this is where you very obviously are able to bridge what a person needs when they leave the hospital or a healthcare setting and move into the next transition. If they're homeless, we need to get them at least some short-term housing to get them through the rest of their recovery. So that's something that you all know very well, but this is what the impact is on healthcare. So I'm going to switch gears and I'm going to check my time to see how I'm doing on time. Great. Privacy and security. Now we're going to do a high-level discussion of privacy and security. And so the Health Insurance Portability and Accountability Act, HIPAA, this is a very old rule, I believe 1996 is when this rule was recorded into law. And it's the federal rule on how we protect and exchange health information for patients. I know that you all have your own set of privacy and security requirements that are unrelated to HIPAA, but similar. The interesting components here about HIPAA, there's a lot of talk about modernizing HIPAA to make it more aligned with the way we do healthcare today, which is mostly electronically. And we have had some changes to it just recently in the last couple of years, but not a significant overhaul to really address how we are doing work. But it's what's important to I think community health workers and community-based organizations about HIPAA. I want to make it as simple as I can. Let me just tell you, I've been in healthcare for about 30 years, and HIPAA is still hard for me to understand. So if you don't understand it, that's okay. You're not alone. It takes healthcare attorneys to help us figure out the right things sometimes. But the point is, covered entities are entities like healthcare providers, physicians, hospitals, health insurance companies, clearinghouses like Change Healthcare, who you all heard of. If you didn't know them before last year, you definitely know who they are now. Business associates is where you may fall into a HIPAA relationship with a healthcare organization. So business associates are people or organizations that are not working for a covered entity. So you're not working for the health plan or the hospital or the physician, but you're doing functions on behalf of that healthcare organization to help serve the people, the patients that they're serving. So the challenge here is it isn't even defined whether or not community-based organizations and community health workers are considered a business associate. So my first recommendation is going to be, you should ask your attorney, hey, what is my relationship, my existing relationship, or the things that I'm considering contracting with healthcare for in order to get reimbursement or share data? Where does that put me? How do I fall into this? And then what are my legal requirements? I will tell you what I would recommend. In the way the systems process information on patients. First, anytime you're going to enter into a contract with a healthcare organization, I would make sure in that contract that there's a requirement that any person that healthcare organization refers to you for you to serve for community service for SDOH needs, I would make sure that the contract with that healthcare organization says everyone that they send you, they have gotten consent from that person specifically to send this information to community-based organizations. So the first step is make sure that they're requiring an informed consent to share the data with you. The second thing is, and this is where you'll need your legal counsel to kind of help you walk through it. Attorneys have differing opinions. Healthcare attorneys and health compliance attorneys have differing opinions on what is the right, what's the requirement, what's the letter of the law. So my most stringent one that I've heard, and this one is reasonable to me, the most stringent one I've heard is, if a healthcare organization refers information to me and I serve a patient, but I don't send that data back to a healthcare organization, then I'm not working as a business associate. I'm just going to take the information from that healthcare provider and I'm going to serve a person. And I don't know any of the healthcare data. I'm not sending data back to that healthcare provider. They just said, hey, you need to go down to, this community-based organization and they can help you find X support for your need. You're not sharing information back, then there wasn't as much concern about whether you would be considered a business associate. It gets a little trickier when that health care organization wants you to send that information back, which, by the way, I very strongly support, because there's really no way to track that organizational and community data if you're not sending it back, there's no really good way to get that data that can kind of make you transition from a reactive to a proactive community. So that is a place where you would be leveraging healthcare payments as part of your contract so that you can afford to send that information back to that healthcare provider, but also get paid for your service. So always find out, require informed consent for them to send you anybody, no matter if you're sending data back. And then work with your healthcare attorney and that healthcare organization to determine what is your requirement for HIPAA. So it's still really undefined because we're in new territory. Now, I know you're not in new territory in terms of the service that you're providing to your community, but we're in new territory where we're combining these two things. So let's talk a little bit about how you get paid. This is really important, and I'm going to be really high level about these to make them. I've been doing this for 30 years, and I can get glossed over with it, and I love this. This is part of really a lot of what I've done for my career is understanding the revenue cycle. But these payments are paid in very different structures. So there's outpatient payments, there's inpatient payments, there are fee for service versus percentage of revenue versus a hybrid. And then there's these two things in the middle, social determinant of health support versus community integrated health support. So high level, on the outpatient side, the physician or even the hospital says, okay, I did a lab stick on this person and I drew blood and I sent it and I'm doing a complete metabolic profile, right? I'm doing a CBC. The health insurance company, Medicare, Medicaid, whomever it is, they're going to pay for that lab stick. They're going to pay a fee for that service. And then for that lab test itself, for that CBC, they're going to pay a fee for service. Okay. So if it's healthcare outpatient, it's going to be mostly set up on a fee for service. Now, there are some other payment schemas that we're not going to get into because they're just really, this is sufficient for you to understand, I think, for how to contract. So basically, if there's an outpatient procedure, you can ask that healthcare provider, what is your healthcare, what does this procedure pay you? And then you could, contract for a percentage of that reimbursement. On the inpatient side, the inpatients are grouped together in what they call a diagnosis related grouping. So essentially, you have this person has a particular condition, and based on historical data since like 1984, that condition in your in the healthcare cycle, that condition should give you a 4-day stay in the hospital. And based on that condition and that 4-day stay, we're going to pay you X dollars. Well, if you have any modifying factors that increase the resource intensity of that person's stay, then that healthcare payment and also that length of stay could go up. So rather than it being 4 days and $4,000, it could be 5 days and $7,000 based on the modifying factors. Well, some social determinant of health diagnosis codes, because all of these have Z codes, some of those Z codes are actually codes that will bump that up to a higher paying DRG. So for your organization, understanding that just enough to say, if this bumps you up to a higher paying DRG, we will take a portion of that to manage care for this person. Social determinant of health support, that's the general support that you do today, no matter where the person is referred to you from. They just have needs and you're able to care for them. Those are not a paid event in healthcare. That is general support that they just try to help coordinate some services for, but they're not necessarily going to be part of that community integrated health support. Community integrated health support is very specific to the impact of a person's condition and their social determinants. So the combination of those things. So those are called health-related social needs. Those health-related social needs are where those condition specific things like we talked about earlier with the medically tailored meals for a diabetic patient? Or what if that diabetic patient has a hard time keeping their utilities on, or they don't have electricity and they don't have a place to keep their insulin cold? Then also they're going to be in the same cycle of running back to the hospital to the ER because they're in diabetic ketoacidosis because they're not able to keep their electricity on and their insulin goes bad because it has to be refrigerated. So that community integrated health or health related social need grouping, that is where it's very intensive, intentional. This person has a condition that is directly affected by their social determinants. And so helping them be able to control their conditions by supporting what their social determinant needs are. It's a very different level. So it is those are paid events, and those can be paid monthly. And the initial visit every month is paid a rate, and then you can have multiple recurring visits every month that's paid a lower rate, but it's still paid events. So you can contract to be paid for those things. So fee for service versus percentage of revenue versus a hybrid, you can make a determination what works best for your organization, being nonprofit, being sustainable already, being semi-sustainable, needing new resources because of taking on a contract with a healthcare organization. You just kind of figure out what makes sense for you. Do you want to charge a flat rate for every time you help manage some outcomes for social determinants, or do you want to have a percentage based on that? So really it depends on what your organization's current needs and future goals are. So technology and data needs. So we'll talk about this in two different segments. We'll talk about healthcare data and technology needs, and we'll talk about community-based organization technology and data needs. So what does your organization need? You certainly don't need to have to buy a new technology system, right? You need a simple interface. You need something that's easy for you to use. You need something that you don't have to have detailed training on. Depending on your organization, you may have, 45 part-time volunteers, and maybe some of them are only volunteering once a month, but they're doing this kind of service. Well, you don't need something that is going to be retraining them every time they work once a month, because they're significant when they're there and they're very helpful to your community. You don't want them to get slowed down by technology, so you need minimal interruption. Your healthcare partner needs, if they're going to do this health-related social needs and ask you for data back, they need interoperability with your systems. They need privacy and security that meet the rule of law for HIPAA. They need availability of the data, and they need that reporting and disclosure back of how things were done. And the types of data that you need between these two organizations is very different. So we've had several conversations with community-based organizations that say, I just need to know if they need food or housing or transportation. And we have healthcare organizations that say, I really need those ICD-10 codes that are diagnosis codes, those Z codes that represent SDOH needs. And I also need any services that were provided. I need that technical data. I need it structured, and I need it to be specific to healthcare. So categorical data has generally been sufficient for community-based organizations, but on the other side of that map, it has to have that structured and technical healthcare data. So some simple interfaces that that exist and that you can find. Maybe there's something that has a very easy interface for people if you're going to be helping the healthcare organizations ask these social determinant of health questions. What are some things that can help you achieve and asking those questions in a very in a very relatable but simple way. So having something that is from a literacy standpoint, easy to understand, easy to read. They have to come from in healthcare. These questions have to be asked from what's considered a peer reviewed and approved tool. So there are several that are out there. Hunger Vital Signs is one, CMS, Accountable Health Communities, the Prepare tool. You're probably familiar with some of these. I think Cubs has one, but there are several out there. But if healthcare is going to be able to use this data from you for the reimbursement, it has to come from those tools. So having something that's simple for your community members to engage with, but underneath it, it's got the complexity of the healthcare data would be important. Having a simple interface where the interventions are identified and you can just click on this, intervention need or this need and then work through helping someone would be important. You don't want to have to, again, recreate training every time someone comes to work. No matter how often they're at work, daily or weekly, sometimes monthly, it needs to be simple interfaces. That's what you will need from your healthcare organizations. You need to be able to see all of the opportunities. So sometimes there's coordination of care, right? So that's not just true of healthcare. So you may be a community-based organization and you may be contracted with a healthcare provider. And in this case, it looks like we are looking at let me go right here and I'll tell you. We're looking at a housing need. And these are some providers that fill housing. So for whoever you're coordinating with, if you were coordinating with Our Daily Bread, you would click Our Daily Bread, and this report would go back to that healthcare organization to say that Our Daily Bread then did this type of service. And this is important because if Our Daily Bread connected this person to emergency shelter, the next time that healthcare provider interacts with this person, they need to know, hey, this person only had emergency shelter, so I need to ask them again if I can help coordinate some housing services for them. If that person got connected to permanent housing, there's less need to ask the question about whether or not there was whether that person had housing insecurity at this moment. They might want to wait 6 months to say, how's everything going, right? Because there's a big difference in transition of care to emergency shelter versus that permanent shelter. So the point is, on this front end, you have the categorical data, but then on the back end, the information that goes back to healthcare, it has to be that structured data so that they understand it. So, and I think we're right at 2:45, and yeah, pretty good. So I wanted to save the last 15 minutes for Q&A, if that's okay with you all. I'd love to answer questions. And you are on mute, Ashley.
Thank you for that. I always start that and forget. So thank you, everyone. If you have any questions, please put it in the Q&A section or in the chat. I will be monitoring both. However, the Q&A section is a little easier for me to read through since it's just the questions. So starting off, how do general social determinants of health needs and health-related social needs differ from the healthcare perspective?
Yeah, so it's a lot about the transition of care and how you're going to manage that person at home. So if let's go with a surgical case. So this person has had a hip replacement, and their social determinant of health, when they're at home, they do not have transportation. So I'm going to send this person home knowing that they don't have transportation. Well, they've had a hip replacement, so they likely need physical therapy. So, and I'm going to send them home. Now, if I send this person home and they have a hip replacement and they're going home and they have a food insecurity, they don't really need transportation, but maybe they need food. Or if they're just lonely, how am I going to handle that? Because that is also, social isolation is a social determinant of health as well. But if I have a person that's going home with a hip replacement and maybe they just need a meal for these 3 weeks, that's going to be a different kind of transition. So the depth of what that need entails is really how this is different. So that person that just needs 3 weeks of meals while they're healing, that is kind of a social determinant of health need, but it's a very short-term thing. this other where I don't have transportation and I can't get to physical therapy and I can't get to follow-up appointments unless someone schedules me and coordinates a ride for me to these things, I'm not going to be able to heal well. Well, that has a direct impact on my outcome. That has a direct impact on whether I walk correctly, whether I have continued pain, whether I have, some kind of an event that requires me to be hospitalized again. So the biggest, easiest way to say the difference in social determinant versus health related is if that person has a social determinant need that is going to have a direct impact, potential negative impact on the outcome for that patient's condition, that's a health related social need.
All right. Next question is, how can community-based organizations work with healthcare organizations to provide services and maintain sustainability?
Yeah, so that goes back to that healthcare reimbursement schema. So basically, understanding how your healthcare organization that's asking you to support them, understand how they're getting paid for any of the social determinant of health work that they're doing, and then contract with them to say, yes, I would love to help you because I know the community-based organizations want to help, but they also have to have sustainability. And if the hospital is going to or a physician's office, whomever it is, if they're going to start sending you new people that have not historically been coming to you, they're adding people to you, to your organization that have needs. So you need to work with them to understand what is it going to cost you to employ another person or three more people or one person full time instead of half time. Was it going to cost you for any technology? And then determine what do you need from that healthcare organization in order to make that the revenue that they're going to send you cover all those. You don't even have to be building in profitability, right? You just have to build in that sustainability because you exist to serve. I mean, I understand your heart, but you still have to be able to serve. So building in understanding enough to say, I know enough about healthcare reimbursement to know you're getting paid for some of this. And I know this much about my organization and what my needs are. Somewhere we have to be able to come together where you're going to cover these costs for the folks that you're sending me. That's how I think that's probably it's a two-sided answer.
Okay, great. Do we have any more questions? Oh, it looks like we have one more. So what do you recommend for handling HIPAA and business associate agreements?
Yeah, first determine, are you okay accepting social determinant of health referrals and not sending information back to that healthcare organization? Or do you want to accept those referrals and then also report back what you did to help that person? So first determine what kind of relationship you want to have with that organization. And once you've determined that relationship that you want to have, and reminding you then that the social determinant of health work that is general social determinant of health it's not a reimbursed event in healthcare. Those health related social needs that have that care and context component, those are the ones that are reimbursable events. So first determine what your relationship is going to be with healthcare. Then you take that to the next step and say, okay, if I'm going to be that health related social need provider, where I'm definitely going to be making sure that this person has everything they need as related to the discharge from that hospital, and I'm going to send them this information back. I need to ask if I don't have a healthcare attorney, I can ask my general attorney to work with that hospital's healthcare attorney that understands law, HIPAA, and compliance to say, okay, what are my minimum necessary requirements? What are the things that I have to do to protect and make sure that you're covering those? And once you're covering minimum protected and releasing minimum information like the minimum expected or required, then you should be able to stand up to an audit.
Well, it looks like that is the last of the questions. So if anyone has any other questions, feel free. You can email me at ashleymueller@nbphe.org. And I'm sure Dr. Swafford would be happy to follow up if something comes up at a later time. But anyways, I would just like to say a special thank you, Dr. Swafford, for coming today. And I hope everyone else enjoyed the presentation, and everyone will have a happy holidays, and I look forward to seeing you all next year. Thank you.
Thank you, Ashley. I would like to say to everyone still on just one thing. I know that the information that I provided, some of it may have been brand new to you, and that's okay. I wouldn't expect it to be something that you've known, but I hope that it gave you enough information to start asking questions of, how am I going to contract or serve the people in my community through this healthcare stream in a way that I do it where I protect my organization and I build sustainability for my organization. And don't let it be overwhelming. You're doing the same work and the same care for your community that you've always done. You're just now doing it under the notion that you could get reimbursed for it and under these rules around HIPAA and exchange. Okay.
Yeah. All right.
Thank
Well, thank
you.
you again. Yeah.
All
And
right.
thank
Thanks
you,
so
everyone.
much.
Happy holidays.
Thanks. You too. Bye bye.
Bye.